virtually meet everybody nowadays. It's kind of crazy, but so I'm going to share my screen. This is a very informal kind of lecture. Hold on one second. So I know for the people who joined yesterday, Dr. Advani, who is a GI fellow, gave the lecture, and she, I think, talked a lot about why she went into GI and what it's like to be a fellow, and kind of some of the different procedures and some of the cool videos that she showed. So for me, now I've been out in the GI practice now for several years. So mine is just more kind of like, what are the different paths that you can take as a gastroenterologist? Where can you work? What are the different specializations that are available to you? So get started. So my name is Supriya Rao. My Instagram and Twitter handle is GutsyGirlMD. So you can find me on either of those. Excuse me. So, whoops, I should actually make this a slideshow. There you go. Sorry. So I am currently a managing partner in a private practice. It's called Integrated GI Consultants. It's located in the greater Boston area. When I started in private practice, you start as an associate usually. So I was an associate for 2 years. And then I became a partner. And I'm also director of medical weight loss, which is why I kind of underwent that whole obesity medicine training at our big community hospital called Lowell General Hospital, which is located about 30 minutes outside of Boston. And as was mentioned, I'm board certified in internal medicine, GI, and obesity medicine. So how did I get to this point where I am in my career currently? So I did 4 years of college, 4 years of medical school. After medical school, I matched into an internal medicine residency. I did that for 3 years. And then after that, I did 3 years of GI fellowship. So undergrad, I went to MIT. Med school, I went to do medicine residency. I was at Penn. And for GI fellowship, I was at Boston Medical Center. And then I graduated fellowship in 2014. And I've been at the same job, actually, which is somewhat unusual for some people. Usually people change quickly within the first couple of years. But I've been at the same practice now for almost 6 years, or actually now it's my 6th year actually at the practice. And then this year, earlier this year, I completed the CME pathway for obesity medicine. There is actually an obesity medicine fellowship as well, but I was kind of done with training. So I just did the CME pathway and finished that this year. So where can you practice once you graduate from GI fellowship? So community-based, so I'm in private practice. So private practice is different than hospital employed. So in a private practice, it's a group and you are an associate for a couple of years, you buy into the practice to become a partner, you are an independent entity. And in private practice, there's both single and multi-specialty. So single specialty would be just a GI practice, or multi-specialty would be a bunch of different practices, a bunch of different specialties that are kind of under the roof of one practice. And then there's hospital employed. So there are community hospitals that can just employ you straight out without you being part of like an independent practice. You can do academics, which is what I initially thought I was going to do. So academics would basically be at like a big tertiary care center, like for example, in Boston, Mass General or Brigham and Women's. And so people can do either basic science research, clinical research, or be a purely clinical person in academics. So there are different pathways there. You can go into industry. I have a lot of friends who left practicing clinical medicine and went to go be like the chief medical officer at a startup or running some type of research at Gilead, for example, in a large biotech firm. And also in policy and government. So I've actually been involved in some policy and government things in terms of doing GI advocacy, colorectal cancer awareness on Capitol Hill. So that stuff is actually really, really cool. You can do, and you don't have to be pigeonholed into any one of these. You can be kind of also any mix of these. So I'm a private practitioner, but I also do some government work, and I also consult for a startup as well. So that's the really cool thing about GI, is that there's a lot of different avenues to find yourself in. So as gastroenterologists, who in the hospital and kind of in general, who do we work with the most? Well, I would say our anesthesiologists are one of our best friends, because they are the ones who provide the sedation for patients when we're doing endoscopy or colonoscopy. Radiologists, for example, help us with the CAT scan imaging that we need to see if we're looking for issues within the gut. Our pathologists are really important because they read all the slides of the biopsies and everything that we send them from our procedures. Surgery is very important. We, work with all these different specialties within surgery for all the different GI issues that come up, GI and liver issues that come up. Oncology, and then obviously our primary care physicians and hospitalists too. So what procedures do we do? There are dozens that we do, but these are the 6 probably most common, I would say. So the first is an upper endoscopy. That's basically where we have this flexible tube. It's got a light and a camera at the end of it. After giving a patient sedation, we put a bite block in their mouth, which kind of protects the scope as well as the patient's teeth. We go down into the esophagus, look at the stomach and the first part of the small intestine. And we use this to kind of look at anyone who may have a swallowing issue, or if they have acid reflux problems or abdominal pain. So those would be the reasons to do, some of the reasons to do an upper endoscopy. The next one is a colonoscopy. We do this screening for colon cancer, any kind of changes in bowel habits, blood in the stool, pain. So those are reasons for a colonoscopy. Again, a flexible tube going down through the rectum into the colon. And we can actually go to the end of the small intestine with the colonoscopy. ERCP and EUS. So ERCP is endoscopic retrograde cholangiopancreatography. So that's basically if you have like a stone in your gallbladder that gets stuck in the bile duct. And so oftentimes we do ERCP to go and remove that stone and make sure that more dangerous things don't happen. That's done via the mouth. Again, it's almost like an endoscopy, but it's a different kind of scope, and that helps to remove stones from the bile ducts. Endoscopic ultrasound, again, is another upper endoscopy procedure, but it specifically has an ultrasound probe on it to look at the pancreas and the liver and surrounding structures to help understand if they're, like on CAT scan, if there is an example of a possible mass in the pancreas. We then do an endoscopic ultrasound to go down, use a very fine needle to take a biopsy of that mass that could be there and maybe possibly diagnose a cancer. So endoscopic ultrasound is a really important tool. The next one is called a capsule endoscopy. So a capsule, so as I mentioned with the upper endoscopy, we just get to the first part of it, like the first few inches of the small intestine, and the colonoscopy, we get the last few inches of the small intestine. So there's about 20 feet of intestines that we miss. So the capsule is really important because that helps us take pictures. It takes thousands of pictures through the entire small bowel and gives us an idea if there's like some possible bleeding that's going on there or inflammation. And then the last one is a feeding tube. And so basically for patients who are having problems thriving, not taking in very much food, had a neurological insult, a stroke, this is a feeding tube that we do place endoscopically and also through the skin, and that allows patients to take food in via like tube feeds. So specialization within GI. So there's a few main specializations. So the first one is inflammatory bowel disease. So that's basically Crohn's and ulcerative colitis. There is an extra year of training available. So after you finish your 3 years of GI fellowship, you can do another year of inflammatory bowel disease training. And so you're basically treating patients with either ulcerative colitis or Crohn's disease. And so the first picture here is an example of a normal colon. The second one is an example of ulcerative colitis. So it basically shows inflammation that's going on throughout. It stays only within the colon. It usually only affects the top layer of the lining of the colon, the mucosa and submucosa. And, there's definitely an increased risk of colon cancer with these syndromes. But ulcerative colitis and Crohn's both require long-term medication. And so while ulcerative colitis is, basically just in the colon, Crohn's disease, you can find it anywhere from the mouth to the anus, and you can get fistula and obstructions and all sorts of other complications. And it affects all layers of the bowel wall. So these patients, they can be really tricky and require a lot of really complicated medications. And so it requires a lot of coordination with radiology, pathology, surgery. These are probably one of our more complex set of patients. Motility, which is one thing that I actually am one of the specialists in my practice. So it deals with movement issues or muscle disorders in the GI tract. So in the esophagus, this is getting like maybe a little too specific, but basically swallowing disorders with the stomach, your food's not emptying fast enough or it empties too fast. So issues there. In your small intestine, you can have bacterial overgrowth. And so that's also a motility issue. And then if you have constipation or diarrhea. And then if you have pelvic floor dysfunction, and actually there are some programs in the country that do offer an extra year for motility testing. Liver disease is another big one. So they're called hepatologists, and hepatologists, they can do an extra year of liver transplant fellowship. They take care of all different kinds of viral hepatitis patients. So A is like not very common, but B and C. Also, they take care of other causes, patients who have other causes for liver disease, so alcohol, fatty liver, and other rare causes. And then oftentimes, if you're at a transplant center, you're getting these patients teed up for eventual liver transplant and kind of taking care of them in the post-transplant setting. But actually a lot of general gastroenterologists do a liver. I mean, I do liver as well. And so I see a lot of these patients, but once they get to the point where they need a transplant, we usually refer them to a tertiary care center to get that whole liver transplant workup. Advanced endoscopy, I think Dr. Rao may have mentioned this last night. She, I think, wants to do advanced endoscopy. So ERCP and EUS, those two pictures I showed earlier, where it was bile duct and endoscopic ultrasound, those fall within the realm of advanced endoscopy. And you definitely need an extra year of training in order to practice out in the community with this. Also stent placement. Oh, whoops, sorry. Okay, stent placement. If you're having some type of obstruction in the colon or obstruction in the esophagus, a stent basically would help open that area up. If there's any cysts in the pancreas that need drainage, they can take care of it. You know, all sorts of different really cool procedures are done with advanced endoscopy. They're almost thought of as like the surgeons of GI. GI is a pretty procedure heavy field. So to do this is actually quite interesting. My husband is a advanced endoscopist and he really likes it. And then there's the field called bariatric endoscopy. And so bariatric endoscopy, sorry, I'm just moving this around, is kind of a newer field, and it's basically in place because of kind of the rising levels of obesity in this country. And it's looking to see how we can help patients lose weight via endoscopic procedures as opposed to surgery. So you may know surgeons can do a procedure called the gastric bypass that allows them to lose weight. So endoscopically, we try and do some similar things. So oftentimes people who have advanced training will end up doing these kinds of procedures. The first couple pictures show balloon placement. So it's basically these weight loss balloons where you put a balloon in the stomach for several months, and that kind of helps patients feel full easier. And so that would be a reason for weight. That's one way for weight loss. Actually, Orbera is the main one that we do. Reshape, I think, was bought by Orbera. Another thing is called ESG, which is endoscopic sutured gastroplasty, which is basically in the stomach, you kind of sew it closed a little bit, so it ends up being smaller. It kind of tries to mimic gastric sleeve procedure. This is called pose. Again, you're just trying to basically decrease the volume in the stomach to help patients lose weight. And this one, I'm not a huge fan of. It's called the Aspire. It's basically that feeding tube I showed you earlier that we place. It's basically a feeding tube that allows you to empty whatever's in the stomach. So that's not done very often because it has to be a very specific patient population, but I'm not a big fan of that. But, you know, the reason I went into GI is because, so the reason I went into internal medicine was when I was in medical school, I really loved my medicine rotation. And I found that kind of like thinking about adult medicine, the scientific thought behind it, and trying to come up with, like, you know, you're presented with a patient who has all these symptoms and trying to come up with a, differential diagnosis. So I really liked internal medicine. And when I did internal medicine residency, I did a GI elective and really loved my mentors on that elective. They were great teachers. And I liked the procedural aspect of it too. And so I ended up doing GI fellowship. And yeah, so basically I think it's such a diverse field. You've got procedures, you've got, I do inpatient work where I work with really complex patients and have to do emergencies in the middle of the night. And then I see my patients in the office. And so I have kind of like an outpatient kind of chronic setting. So I see patients for urgent reasons. I see patients for non-urgent kind of mundane reasons. So I think it's a good mix of everything. And then, like I mentioned, I do some startup work as well as some kind of advocacy and government work as well. So it's kind of cool to have lots of different, your hand in lots of different pots and get kind of that fulfillment from not just clinical medicine, but other things as well. So, you know, just I'm open to any questions. It's just kind of a short summary of what we do as gastroenterologists and the different things we can do. So I'm happy to take any questions that people may have.
Thank you so much for that presentation. That was really awesome. There are a lot of questions, so I guess we'll start. So a lot of people have questions about the bariatric surgeries that you do.
Yeah.
And there were several people asking, so do the balloons, do they dissolve? Are they excreted by the patient? Do you have to take them out? How does that work?
Right. So the Orbera, which is what the main one that's used right now, what happens with that is it's placed, it's filled with this liquid, which is colored blue. So if you end up peeing blue, if you've had this placed, you know that it's popped and it's no longer there. But it's only in there for about 6 months. The whole thought behind it is that for 6 months, you're taught that, you know, your stomach is smaller in theory because it has a volume occupying thing there. But then you're also supposed to undergo like behavioral therapy as well as nutrition therapy. And so like all these things should make you kind of change your behavior and the way you eat. And then after 6 months, it's removed. And the hope, I mean, these are still relatively new, so the long-term data isn't really there quite yet. But the hope is that because you've changed your habits, it'll continue in the years after.
Great, thank you for clarifying that for us.
Sure.
There are also people wondering what some of the complications are for bariatric surgery, short-term, long-term, or just in general.
So we don't do the surgery part of it, we do the endoscopic one. So if a surgeon does a gastric bypass, like a laparoscopic gastric bypass, so I see a lot of those complications actually as a gastroenterologist. So what can happen with those? Sometimes you can get ulcers at where the connections are. You can get a hernia, which is like some of your bowel poking out. You can get, I mean, some leaks sometimes, like if the connection is not done properly, you can have some leaks. Over time, a lot of people, well, not a lot, but like maybe 30 to 40% of patients who have bariatric surgery end up regaining their weight. And so that's when they come to see me for medical weight loss, or, you know, they may try an endoscopic therapy.
Great, thank you. We had some questions asking about what kind of urgent cases would you be seeing, if any?
Yeah, sure. So the classic 2 a.m. food impaction. So basically, you know, if people have some underlying issue in their esophagus that's like not allowing them to swallow properly, a lot of times they change the way they eat. They have smaller bites of food and stuff like that. But the food can get stuck in the esophagus. So basically, you know, at 2 in the morning or whatever time, but it always seems like 2 in the morning. We have to go in with an endoscope and kind of use different tools to either push that food down or pull it out. And so that's an emergency, because if the food is left in there, it can cause like your esophagus to tear, which then becomes a true emergency. Another one is if you have an acute upper GI bleed. So if you have an ulcer with a vessel that's spurting blood, that's definitely like something that we need to come in emergently overnight. Another one is like if you have cirrhosis. So if you have liver disease, chronic liver disease, and basically blood vessels can get larger in your esophagus and those can burst. And so that's another, I mean, if you don't treat those patients, they can potentially die. And so that's another emergency. From an advanced perspective, emergencies include in the bile duct system, a stone can get stuck and cause something called cholangitis. Cholangitis is basically when you get an infection in the bile duct, and so getting those stones out immediately is kind of an emergency as well.
Thank you. We had one question that apparently a lot of people wanted to know the answer to. What are the pros and cons of working in private practice versus hospital setting for gastroenterology?
So hospital setting, do they mean academics or hospital employed in the community?
You guys let us know what you mean by that. Let's maybe say a hospital, like the actual hospital for now, or both.
Like an
Some
academic.
people said both. Yeah.
Oh, okay. So, you know, when I was in fellowship, I thought, you know, because I'd only done academic medicine at that point, I'd only jumped from one academic center to another. And so I felt like I was probably just going to stay in academics. There's a lot of obviously benefit to that. You get, you know, a huge department. that's kind of behind you. You know, if you are really interested in research, I would say you should stay in academics because that's where most of the big basic science research is done. I think now more and more clinical research is done, obviously, at major academic centers, but there is clinical research being done in the community as well. So I think that doesn't necessarily like, you know, pigeonhole you to specifically academics. But I would say the pros for me, the reason why I chose private practice is because I really I think in the end, you have to like the people that you work with. And so the people who I interviewed with were really supportive. I wanted to bring, you know, some of the motility studies that I was mentioning earlier. I want to bring that to the community because a lot of people who don't live right in the city don't necessarily want to drive even half an hour, 40 minutes to get some of these things done. And so I want to be able to bring it out to the community. And so, you know, for me, it was kind of like that balance of being able to do good clinical medicine, being able to build programs that I wanted to on my own and not come into something that someone else has already built. Having autonomy over my schedule. So not having people say, you have to work this day, but almost just being my own boss essentially was really important to me. And, yeah, those are the main reasons. And I felt like it made life a little bit more flexible for me. I have 2 small kids, so it was much better for me in that way.
Great, thank you for expanding on that. There was a lot of people that were really interested in the government work that you mentioned.
Sure.
And so can you kind of talk about how do you fit that into your private practice schedule, your family schedule? How do you work in doing that government work?
Sure. So so we have GI societies, like, so any medicine specialization will have like the American Cancer Society or the American whatever society. So for us, there's the American Gastroenterology Society, which is the AGA. We have the ASGE, which is the American Society for Gastrointestinal Endoscopy. And then we have the ACG, which is the American College of Gastroenterology. And then there's like some other ones too that are like liver based and stuff. And there's one for prior practice specific, prior practice gastroenterologists. It's called the DHPA. Anyway, so all of these different societies have a bunch of different committees. And when I was a fellow, I got involved with the ASGE's Health Policy Committee. And so a couple times a year, we would go to DC, meet with staffers. And actually, I met with a couple senators and representatives from Massachusetts. And we just talk about the different bills that are being introduced. So for example, there was one about colon cancer screening. And so like you're just talking to some of these people to make them aware because they get so many different things from their constituents that their constituents want them to talk about in Congress. And so it's just a good way for us to go out there and be like, hey, colon cancer is a really big issue in this country. So making sure everyone has access to screening is important, making sure all these different things. And so when I was a fellow, I got kind of a taste of it. And then and then within the AGA and the DHPA, I've been able to get involved as well there. And so it's kind of like on the side. So sometimes there are meetings like, you know, at 8 o'clock at night that we do a couple of times a year. It's not that, sometimes it's as much of a commitment as you want it to be. So for me, it's kind of like, you know, low to moderate commitment, but I'm able to actually I was in DC right when COVID hit and they were shutting down Congress. So it was kind of like an interesting experience back in March, but it's really cool to kind of see how things are moving in action on the Hill.
Yeah, that's awesome. There's a lot of people really interested in kind of the government work and really.
Yeah, so you can see government work like that in all fields. Obviously, I'm biased towards GI, but you can see it a lot in a lot of different specializations.
Yeah, that's awesome. Thanks. There were some people wondering about pediatrics in gastroenterology.
Yeah.
So are you trained to deal with the pediatric population?
No, so I'm trained for 18 and older. So if you want to do pediatric GI, you have to do a pediatrics residency, and then you do pediatric GI fellowship after that.
Great, thank you. We actually had a question about if you work with PAs and if they're like more specific for gastroenterology, and do you see them more in private practices, or would you see them more in hospitals?
So we have actually, for whatever reason in my practice, we have NPs as our kind of advanced practitioners. It's not because we chose that, it's just whoever was, you know, interviewing at the time. If an appropriate PA came along, we would be happy to interview them and hire them on as well. The way that we use our advanced practitioners are basically in the clinic setting. So they see a lot of patients for us. And if they have any questions, obviously we supervise and things like that. But and then we also have NPs who are helping us see consults in the hospital. So for example, I'm working in the hospital, someone from like the inpatient service calls me. It's like, oh, there's a patient, we think they might be bleeding. Sometimes I'll send, our nurse practitioner to go check that out, see, do we need, to do a procedure or something like that. Then we discuss the case and then we, move from there. So that's how we utilize advanced practitioners, basically in the office, in the hospital. They don't do procedures, they're just seeing patients. But they are, I would say advanced practitioners are equally seen in both private practice as well as in academics.
Yeah, that's great. We actually have a lot of questions asking about what it's like being a woman in medicine, a woman in gastroenterology, and just some of your experiences through medical school and, in practice.
I have to say, I think I was pretty spoiled in undergrad, medical school, and even residency and fellowship, being a woman in medicine. When I was at Duke, half the class was female. Actually, when I was an undergrad, half my class was female. And I would say in residency, most of 60% of my class was female. And in fellowship, I was one of 3 GI fellows, but I was only female, but there were other women in my GI fellowship, just not in my year. I would say once I left that shelter of, being in a higher institute of learning, I would say, that's when I started feeling a lot of the sexism, racism, ageism that I think people feel daily. It was really hard. Like the first few months of being an attending physician, you're always second guessing yourself. I mean, I was very well trained, and so but you're thinking, oh my God, if someone's questioning me, then am I doing something wrong? Is it me? I think it's really easy to basically get down on yourself and have imposter syndrome. I had imposter syndrome for I still do. It's just one of these things where you just carry it with you, but you just try and rise above it. But it's hard. GI is, I think 18% women. So it's still overwhelmingly a male dominated field, I think because of the procedural aspect, the call aspect of it. So it may not be as friendly in some ways for females, but I love it. I wouldn't change to any, knowing what I know now, I wouldn't, choose a different path. But I do think, as women in medicine, we have our work cut out for us on a daily basis, but I do think it's getting better. I think more and more women are going into GI. So when I joined my practice, I was the first woman. There were 4 men. I was the first woman. I had to write in a maternity leave clause into my contract and make sure things like that were taken care of. And then then my husband actually joined my practice after me, but after him, we've hired only women. So it's really cool. I'm trying to pay it forward and make sure that you pave the way for other people to follow. So.
That's great. There's a lot of female attendees today that are really inspired by that. So thank you for sharing your story. Now, kind of shifting gears, there's one question, and then a lot of people seem to have the same question about how COVID has impacted particularly your patients. So in particular, this question was about gastric and obese patients and how it's changed how you treat them, their risk factors, just things like that.
Right. So when COVID hit, basically all of our procedures were shut down. We couldn't do our regular elective procedures. We could only do severe emergencies. So those 4 different emergencies that I was telling you about, those are the only things we could do. We're a pretty procedural based specialty. So we basically had to move to all telemedicine and kind of office visit stuff. And we would say, okay, I know you need your colonoscopy, but we need to wait until the pandemic is over. But now basically since September, we've been back up and running 100% pretty much. But, I was worried always about the delay in some care just because we were okay, we have to put this off for a few months. So there was a concern about that. In terms of patients with obesity, so as we know, as we've continuing to learn about how COVID affects people, patients who have an unhealthy weight tend to have higher risk factors associated with COVID or more hospitalizations or worse outcomes. So for any patient of mine, especially my weight loss patients, I'm not trying to say you need to be on a diet. Oh my God, COVID, whatever. I'm just saying that patients really need to think about their health in a way that is sustainable for them. So if you are at an unhealthy weight, you have all these other medical conditions, what changes can we make to help you, lose some of that weight in a way that you will be able to do. So like if I tell someone, they need to go from like being a complete carnivore to just a vegan, like that's impossible, right? So like we need to be able to come up with ways that are sustainable from a diet perspective, from an exercise perspective. And it's not just that, it's also like, what are your stress levels? Obviously this year has been a year full of stress. And so how do you manage that? What avenues are you taking? Are you doing meditation? Are you doing what other ways are you able to manage your stress? Are you getting adequate sleep? That's another thing. We are a very sleep deprived nation. So making sure we get 7 to 8 hours of sleep a day is really important. Getting outside, all of these things. So that's what I talk to my patients about.
Great. Kind of going off of that COVID question, what do you think about the future of telemedicine and telehealth, particularly in gastroenterology or just the medical field as a whole? Where do you see it going from here?
I think telemedicine's here to stay, honestly, like not for every patient, but actually about a year ago, I went to a conference where I had listened to a lecture about people doing telemedicine already. And it was for more like kind of these non-urgent visits. So like sometimes I have some patients who I see once a year for their acid reflux. It's well controlled because they take a medication. And so their heartburn symptoms are totally under control. So for those patients, it's more of a check-in, a social visit. Honestly, I see them, we talk about what books we're reading and they're usually fine. So for those patients, I feel like a telemed visit would be super easy. Only patients where I feel like a true physical exam is really necessary. But telemedicine's actually, we've been doing telemedicine since March and we haven't gone back into the office yet just because of cases rising and falling and just the uncertainty of it. And so at this point, I think telemedicine's not going to be there for everybody, but I think it does have a place for patients that, some chronic conditions and some really easy, like conditions that are controlled.
Yeah, that's definitely true. We definitely want to keep our virtual sessions as well, so we understand that. We actually had a really interesting question, basically just asking about the, let me see if I can find it, how DOs are viewed in gastroenterology and how, if you would recommend anyone doing the DO route, and how competitive the residency programs would be for them.
So I don't actually know too much about DO medicine, honestly. I do know there definitely are there are people who go to osteopathic school who match into internal medicine residencies and GI. There definitely are. I know a few. I just personally don't know myself because I did not do it.
Yeah, that's completely fair and valid. So we can move on.
But it's definitely possible. It's possible for sure. GI fellowship is a pretty competitive fellowship, but I think as long as you meet the similar metrics, it should be similar.
Yeah, I think that's kind of the point of the question, was just see if it's even possible. So that's good to know.
Yeah, definitely.
The sky's the limit, guys. There's a question about how much manual dexterity is involved in GI procedures, and if it's a high amount that's required, what advice would you give to those who struggle with tremors?
Oh, interesting. I've always heard that you should play video games. I don't know how true that is. My husband's really good at video games and he's an advanced endoscopist, so maybe there's some correlation there. I played video games growing up, but nothing like crazy gaming or anything. But so I entered GI fellowship having never touched an endoscope or a colonoscope. When I was on my ICU rotations, I would do putting in IVs and things like that, certain blood vessel catheters, but I've never done anything procedural to that extent. The first year of GI fellowship is basically stumbling your way through procedures. It's awful. You feel so it's not awful in the sense of oh my God, this is an awful experience. It's more you feel so dumb because you can't do anything right. And so you're learning, you're like stumbling in the colon. Oh my God, like upper endoscopy, I would say you can get within 2 to 3 weeks. Like you should be able to do it. It's a pretty quick procedure. It's usually about 5 to 10 minutes. Colonoscopy is just really hard. But once you've done like, I don't know, 300 or 400, you can do it. It's just like one of these things, like over time, the more you do, the better you get. Like colonoscopy is a breeze now. So, and in terms of manual dexterity, like I know people who just like, you know, who would again stumble their way even all throughout fellowship, but over time, the more you do, the better you get.
Great.
And for tremors, again, I mean, that's hard. I don't know exactly, but I think that it's not as exact as surgery. You're given a little bit of wiggle room to like be not truly exact or anything like that. So I feel like it's probably better for tremors than surgery.
Awesome. Thank you so much. I think people are definitely wondering kind of that learning curve and how easy.
Yeah. Oh, it's like you feel so. I remember I would just like every day go home for the first 3 or 4 months, be like, oh my God, I need to quit. I can't do this, but everyone gets it. So
that's good to know. There was a lot of questions about just research in GI. And so one of the more particular questions was, what research would you recommend that college students, pre-med students try to get involved with if they're interested in going into GI later on?
So that's funny because I didn't even know I wanted to do GI in college. I didn't even know I wanted to do medicine in college. So like I changed majors my junior year of college, and then I ended up taking a year. I should have actually written that in my path. I took a year off between college and med school, which to me was really helpful. I did oncology research, actually. I did research in multiple myeloma, so nothing to do with GI whatsoever. I think that as long as you choose an interesting research project, something that you can talk about and something that you can show that you were really involved in from the beginning of like thinking about it all the way to like executing it. I think that is more important than necessarily doing GI specific research. I would say if you're in medical school or in residency, then you should think about more kind of specializing. If you want to do GI, then you should do GI research. So whether that's case reports or whether that's coming up with or being part of clinical trials or things like that, I feel like that's a lot of there are a lot of different studies going on at the major academic centers. I'm sure mentors are always looking for people to work with. So it's pretty, I'm not saying it's easy, but I think if you show interest and show an eagerness to learn and put in the hard work, I think anyone would be happy to have you along.
And then kind of going on off of that, there was people wondering, as a private practice physician, if you would want to, would you still have the opportunity or the resources to do research?
So my private practice, I would say, is small compared to some of the other private practices across the country. There are private practices that have like 60 strong gastroenterologists, and so those are pretty big. And those have very robust clinical research programs going on with them. They have clinical research coordinators, they have the clinical trials going on. It's really quite interesting. And actually my practice has now been in talks with some of the pharmaceutical companies to start doing clinical research, because they realize that when people go see a gastroenterologist, most of the time they're going in the community. They're not going to like the MGHs and Brighams of the world initially, most of the time. So they're realizing that if they want to be able to see a patient who hasn't been seen by another gastroenterologist, like going to the communities where a lot of the research should be done. And so we're looking into starting up a fatty liver research program, an inflammatory bowel disease research program. It just takes a little bit of time and a little bit of creativity, but I definitely think it's possible for sure. If you have an interest in doing it, I would not shy away from private practice, because I think the shift and those lines are getting blurred with regards to research.
Yeah, that's great to hear. Everyone is also saying thank you so much for that advice.
It's just like, I feel like private practice is always like looked down on a lot, because everyone's like saying, oh, you should always, I mean, I drank that Kool-Aid too. I was like, oh my God, I have to be in academics my entire life. But I think most gastroenterologists are like in the community. And so to basically say that they don't have a voice or they're not as important is really silly, I think.
Absolutely. So that's good to know. There are a few questions that were really just kind of focusing on something you said earlier about imposter syndrome and how you didn't let that hold you back, and any burnout or stress and stuff, how you coped with all that.
Right. So imposter syndrome, one of my friends on Instagram, Kristen Coleman, I believe, Kristen Yates Coleman, she does a podcast on it. And so I was on her podcast talking about imposter syndrome. But she like talks to all sorts of different people about it. It's really cool. It's a great way to kind of like, it's very cathartic to talk about. Basically, you know, like I said, I felt very confident throughout my training, but then when you're out on your own for the first time, people don't care where you trained or what you've done if they don't feel like you're, doing, or if they feel like you're totally green, or they look at you and they're used to seeing like perhaps someone who looks a little different that should be their physician or their proceduralist. I feel like it's hard to overcome those biases, right? And so you have to just continuously teach people in a non-threatening way how to approach you. And so like if somebody says, oh, hi, sweetie, and stuff like that, like obviously you shouldn't be addressed like that if you're a physician. And so you'd be like, oh, you can say like, oh, you can call me Dr. Rao, or, if they try to address me by my first name, like same thing, like, you just politely correct people. But I think one of these like things that people have said before, and I think people have said, fake it till you make it, honestly. Like, so even if you have that imposter syndrome, just like, don't let it hold you back. Even if you're feeling it. I think Michelle Obama said like, she would feel that way when in like a group of all these like really heavyweight type people. And then she was like realizing they're not that smart, or she was just as smart as them. That's almost always the case. People think they're a lot, like the people that you surround yourself with who you think are, oh my God, these people are so smart. Oftentimes you're as smart, if not smarter than them. So I don't think you should ever hold yourself back in that way, because you're just doing yourself a disservice. You should never sell yourself short. And you should always just like be confident in who you are. And once I start to learn that, once I start to be like, you know what, I do add value, I know what I'm doing, then you kind of start to get over it. But I mean, I still grapple with it to this day.
Absolutely. That's good to know that it gets better.
Yeah.
And a lot of people said that was all great advice. So thank you again. And could you mention the name of the podcast again?
Sure. I think it's Imposter Syndrome with Kristen Yates Coleman. Let me just look that up really quick so I'm not doing something incorrect.
You can DM it to us and then we can post it on our story for them.
Sure. I'll do that.
Yeah. So we'll do that for you guys. And then we had some questions kind of going off like if you had to kind of learn how to manage a business because of private practice and what that experience was like.
So one thing that you never learn in undergrad, med school, residency, or fellowship is anything about business, which is so sad because this whole world is a business in a way, right? So, and especially if you stay in academics, you don't really learn any of that part. But as being in prior practice, I would say that like I got a lot of on-the-job training because you're launched into, like as an associate for the first years, your head is down, you're just trying to do your work and get out of there. You're doing your procedures, you're seeing your patients, but you don't think really too much more about it. Once you buy into a practice, once you're a partner in a practice, you want to see it succeed. You want to see it, thrive and grow and expand. And so how do you do that? So you're trying to like read the market, you're trying to understand, you need to learn all about Medicare, Medicaid, insurances, billing, how do you bill appropriately? All of these things like that I never would ever think about and no one ever tells you about. So like at one point I was like, oh my goodness, I wish I had done an MBA or, something like that. But you don't need it unless someone is paying for it for you, I would say. But I think that a lot of on the job and kind of experiential learning is really important, but whatever you can do. And I think there's a lot of free webinars and stuff online that you can get into with it. So I think I would definitely look into that.
Great, thank you. I'm actually planning on doing my MBA next year for my gap year.
Great.
So it's kind of cool to hear that it will be useful and that it will.
Yeah, I definitely think it would be. Yeah.
So we're going to kind of shift gears. There were some questions asking about your patient population. So what is there a certain population that you see have certain diseases more or that have less access to GI treatment? If you could just kind of give some numbers or just what trends that you see in your practice.
Yeah. So in training, I was kind of like in, inner city Boston. So I would see a lot of, my patient population there were a lot of Blacks and big Hispanic or Latino population, Cape Verdean, which is interesting, Haitian population as well. So I think, in general, underrepresented minorities do have poorer outcomes in medicine. As we know, there's a lot of healthcare disparities with kind of mistrust of the system for good reason, and just like not as good access to care or seeking care when things get a little too far along the path. So I've seen like kind of that kind of racial disparity issue from the get-go. And where I practice currently in like kind of the Lowell and Merrimack Valley, there's actually a very large Cambodian population that we have. It was after Pol Pot and like the killing fields in Cambodia. There were a lot of refugees who came over, and kind of northern Massachusetts is the second largest settlement of Cambodian immigrants. And so it's kind of interesting. So we see a lot of hepatitis B in those patients. So East Asians have a higher incidence of hepatitis B, and so we're have to treat those patients. But I would say again, like the typical underrepresented minorities are the ones who have issues with disparities to healthcare and access to care, and so we obviously treat everyone the same as best as we can. So we try to reassure patients, and there's a lot of mistrust, and so trying to gain trust of patients is really important.
Yeah, thank you for that. I think a lot of us wonder who will be treating in the future and how we can help out those populations. So thank you for that. So one last question before we do our wrap up is, someone asked if you think that non-medical related work in between undergrad and medical school, so during gap years or like summer work, do you think that can still be looked on as beneficial on applications and during interviews?
So sorry, the question is, do I think a gap year is helpful?
I guess a gap year is helpful. And also like, do you think that doing non-medical related work is like,
for example,
I think just like things you're passionate about, I don't know.
Yeah, I would say you should not do like something just to put it on your resume and say, I did it. Whatever you do, you should want to do it, because I'm a firm believer of that, because I think in interviews, it's very easy to tell. And I've been in interview for undergrad and med school, and I've gone on like interview dinners with residency applicants. It's really easy to tell what people are passionate about or what they just did to pad their resume. So I think in the end, it's more important if you want to work with like a startup or work with like an NGO or something. I think instead of doing like bench research, because you're passionate about that, that's more important.
Absolutely. That's very important. Everyone should remember that. Let's do one more question, then we'll wrap it up. Do you have a specific order about how you like to go about doing a diagnosis? Is there a system that you have going for you?
So GI like covers a lot of organ systems. Another reason why I chose it, because it's not just one organ. It's the esophagus, the stomach, the large and small intestine, the liver, the pancreas, the gallbladder. So it's a lot of different things. So I usually start with, okay, if they're having pain, where do they have pain? Where is it located in the abdomen? Is it on the right side, the right upper side? Then I think about gallbladder pain or liver pain. Is it on the left side? Then maybe it's the stomach. Is it lower? Maybe that's the colon. So it just really depends on the kind of symptoms that they're having. So I think about their symptoms, triage that in my mind. Okay, they're having X or Y symptoms, changes in bowel habits. And then kind of like go down my list of like, okay, these are the possibilities it could be. What is the way to diagnose it? Blood work, like some type of radiology or imaging testing. Or do we need to do a procedure like an endoscopy or colonoscopy? So that's kind of the way I think about it, from least invasive to most invasive. But usually by the time they're coming to us, it's usually for a procedure.
Awesome. Thank you so much. So I think we're going to just ask one more question. And I think a lot of people asked throughout this chat too. Is there any advice you have for us as college students, pre-meds, during the pandemic that's hopefully going to be—
the vaccine is right around the corner, everybody.
Yeah, so if you have any
I just think
advice.
if you're passionate about something, you should follow it, and like don't let people tell you you shouldn't do something. I think there are a lot of people out there. I feel like I followed a more slightly traditional medicine route, except for that gap year. At the time I was doing a gap year, everyone was like, "What are you doing?" But I think that in general, you should really be passionate. If you are passionate about medicine, then you should do it. Don't think about going into medicine for the money part of it, because it's really not, you know, the number of hours you work, especially during training, doesn't really add up. But I would say that, you know, if you enjoy taking care of people, if you enjoy certain aspects of research, if you enjoy learning about human disease, trying to figure out ways to treat human disease, those are the reasons why you should go into medicine. Pandemic is hopefully over within the next, well, not over, but like, you know, starting to, with the vaccine and everything, improve. Whatever, like shadowing opportunities like this, I think are really great. There are a lot of physicians on Instagram. I think a lot of them are fine if you reach out. I'm fine if you reach out directly, if you DM me or anything like that, just to answer some questions. I think when I was going through this, it would have been amazing to have had someone to ask a lot of these questions, because I didn't know. I was going into it totally blind. There are no physicians in my immediate family. So for me, I was just kind of making it up, went along and hoping for the best. And I think it's important, like burnout and everything is a real thing. So making sure you take care of yourself, and self-care is really important.
Absolutely. Well, thank you so much for joining us, and we appreciate all of your great advice and us all about the rest of gastroenterology after Dr. Advani last night. So we really appreciate you being with us tonight, and there's so many chat messages just saying thank you, and they really loved all your insight and
Great. Glad to help.
the details that you gave. So
if you open it up, you can read all the messages that are
Oh, great. But yeah, so I'm on Instagram at GutsyGirlMD. The last few days have been kind of crazy, so I haven't posted in the last few days, but I do a lot of GI, obesity, medicine kind of stuff. I do a lot of food. I'm plant-based, so I do a lot of food stuff. So it's just kind of a mix of things. So follow me if you're interested in my content. That'd be great.
Thank you so
so
much
we
for
put
your
your
time. We hope you have a great rest of your night and week.
Thank you so much. Take care.
Thank